Unequal pupils. General features. There is a clear clinical distinction to be made between patients who are noticed to have anisocoria but are asymptomatic, and those in whom the unequal pupils are part of a well-defined symptomatic disorder, e.g. brainstem stroke. In a normal pupil, miosis is caused by stimulation of the parasympathetic efferent fibers in the oculomotor nerve, whereas mydriasis is caused by activation of the sympathetic fibers from the superior cervical ganglion. NB. Simple or physiological anisocoria, less than 0.6 mm, is seen in about 20% of normal people. Eye examination. Which is the abnormal pupil? If the pupils respond to direct light, proceed to inspect them in bright and dim light. If anisocoria is greater in bright light than dim, then the iris sphincter on the side of the lesion is defective. This indicates that there is a local iris problem or a parasympathetic defect such as oculomotor palsy, i.e. the problem is on the side of the large pupil. If anisocoria is greater in dim light than bright, then the iris dilator muscle on the side of the smaller pupil is defective. This indicates simple anisocoria or Horner's syndrome, I.E. The problem is on the side of the small pupil. Having decided which is the abnormal pupil, then look for those of the following specific features that are relevant. Ptosis. Irregularity of pupil. Inflammation of the iris. Light near dissociation. The pupil does not react to light but does to accommodation. This is tested by asking the patient to look at something in the distance and then to focus on your finger held reasonably close to the patient's nose. Afferent pupillary defect. The pupil will not react to light because of optic atrophy or severely diminished visual acuity from another cause. The swinging light test is used. On shining a light directly into the normal pupil, it will constrict and so will the affected pupil through the consensual response to light. On quickly moving the light to shine directly on the affected pupil, it will dilate because it has an impaired direct response to light. Ophthalmoparesis. Optic atrophy. Horner's syndrome. Consists of miosis, ipsilateral partial ptosis and sometimes anhidrosis. Anophthalmos is not a useful sign. If anhidrosis affects an entire half of the body and face, then the lesion is in the central nervous system. If it affects only the face and neck, then the lesion is in the preganglionic fibers, and if sweating is unaffected, the lesion is above the carotid artery bifurcation. In the patient with Horner's syndrome, look for wasting of the muscles of one hand. This indicates a T1 lesion and flags the possibility of a Pancoast tumor. Argyll-Robertson pupils. This is almost always bilateral and consists of small irregular pupils that show light near dissociation, poorly reactive to light, with better constriction to accommodation. Holmes-80 syndrome. There is usually unilateral pupillary dilatation with poor constriction to light and accommodation, occurring in association with depressed deep tendon reflexes. This commonly affects young women. The pupil may become small over time. Further discussion. Would you like to ask this woman some questions? Your initial question would naturally be to ask the woman if she was aware of the problem with her pupil or had any other problems with her eye or brain. Regarding ocular and visual symptoms, check the following, the answers to which may be no. Is there any pain or redness, which might indicate iritis or acute angle closure glaucoma? Does she have any diplopia, suggesting oculomotor palsy in this context? Does she suffer from a headache? Both migraine and cluster headache can cause episodic Horner's syndrome, which may become permanent. Does she suffer from photophobia when moving from dark to light? This is caused by a fixed dilated pupil failing to protect the retina in bright light. Is there a history of poor night vision in a patient with small, poorly reactive pupils? If she says that she has no ocular and visual symptoms, then it would be appropriate to make a brief inquiry about any general medical problems and follow any leads that this produces. Note new chest symptoms, particularly if she is a smoker, Pancoast tumor. Also check vascular risk factors and take a drug history, which must include the use of eye drops. What would be your approach to investigations and management? This depends on the findings of history and examination. Remember the following. Any patient with bilateral tonic pupils, poorly reactive or irregular pupils, or pupils with light near dissociation should have a VDRL, venereal disease research laboratory, test. Perform a CXR in cases of Horner's syndrome, especially if preganglionic. Imaging of the carotid artery in postganglionic Horner's syndrome. Imaging of the head is only required if other neurological features are present. NB. Think of Pancoast tumor. Look for unilateral wasting of small hand muscles. Obtain a CXR.